best thing. And really, the color of that fruit. What if you have a brown yellow banana versus a green banana? Those two types of foods are both bananas, yet they have vastly different glycemic index responses. So in terms of that, it could be very difficult to clinically prescribe this to patients. With that sort of in mind, then thinking about the types of carbohydrate quality, whole grains has become quite of interest as of late. And there's a host of mechanisms that may be at play for why whole grains are beneficial for health, in particular by lowering type 2 diabetes risk. So as a postdoctoral fellow, I've been the project manager of a whole grain trial in which we had assessed really the effect of whole grain versus refined grains on cardiovascular risk factors and body composition in adults. And the hypothesis was that a whole grain diet would reduce glycemic excursions, thereby contributing to improvements in insulin sensitivity and cardiometabolic health. What we had done was design a counterbalanced crossover trial in which individuals, target goal of 40, underwent screening processes and then received either an intervention diet of whole grains or a control diet. If undergoing the intervention diet for 8 weeks, they would then cross over following an 8 to 10 week washout and receive the control diet later on. In this sense, both diets were matched on energy content, and blood markers and urine collection were sampled frequently throughout the intervention at weeks 0, 2, 4, and 8. And importantly here, that whole grain prescription was 50 grams per 1,000 calories, which is actually double the current recommendations, yet when looking at international levels, this is quite in line with in the medium of that. So we tried to apply this to be generalizable to as many people as possible. With the goal of 40, we had approximately a 14% attrition rate. So in the end, we had 33 individuals complete the intervention. The mean age was approximately 40, with a BMI of about 30, suggesting our folks were relatively young, middle-aged, and obese. Now, as I mentioned, the goal of the intervention was to have this isocaloric feed, and we had done this through WaveX. Characterizing what we found is that there were no caloric differences between our two groups, and as expected, the whole grain trial had more whole grains. And the fiber content, although similar, was statistically different by about 7 grams. And the composition of the diet was mixed, such that it was about 55% carbohydrate and 30% fat. So with this in mind then, the diets were successful at the intervention, and now we were interested in how that whole grain effect may influence body composition. We really found, though, when looking at body weight, body fat, or even central adiposity, there were no differences between the groups, suggesting that whole grains have no additional favorable effects on body fat. When we looked at blood lipids of triglycerides, or total cholesterol, or LDL, or HDL, we noticed the same thing. There really didn't seem to be any difference in favorable effects, such that, in general, blood lipid levels were improved in both interventions. When we looked at blood pressure, in terms of systolic, we noticed reductions of about 3 points in both conditions. However, this was only significant within treatment of refined grains. And when we looked at diastolic blood pressure, however, we noticed that the whole grain had significantly lower diastolic blood pressure compared to the refined grains. Collectively suggesting here with some of the cardiovascular markers that whole grains and refined grains appear pretty similar in lipids, but may favor slightly greater reductions in diastolic blood pressure, which could be clinically relevant given that this population is under the age of 50. What was also interesting about this study, since I'm kind of a sugar phobe, and I love sugars and I want to know about carbohydrate metabolism, is we looked at a subgroup of this population, specifically glucose metabolism related mechanisms. And what we wanted to understand was really the improvement in glucose tolerance as well as insulin sensitivity and insulin secretion. So we used a 75-gram oral glucose tolerance test over a 4-hour period. And we used actually a dual tracer approach, which is uniquely different from the clamp I previously described, in that this gives us the actual ability to assess gut meal appearance. In other words, we can get a gut glucose absorption, as that's going to be the third component to regulating blood sugars in comparison to hepatic glucose output as well as glucose uptake. We also used indirect calorimetry to assess substrate oxidation as well as metabolic flexibility during the test to gain insights into how glucose may be disposed of once in the cell from a whole body. When looking at blood glucose, we found that with both of our trials, there were slight reductions, but no statistical changes in fasting glucose. Yet when we looked at postprandial glucoses, or glucoses area under the curve, we found that whole grains were successful at reducing glucose, yet whole grain, or refined grains rather, increased this level, suggesting overall that whole grains are beneficial for lowering postprandial glucose levels. So the next question became, well, how does this work? How are whole grains acting to lower glucose? So in looking at glucose meal appearance, we found that in our interventions here of before intervention and after in red, that there were no differences. We didn't find any statistical differences in the change in glucose absorption, suggesting overall that this is not a factor in regulating blood sugars. So when looking at the liver to determine hepatic glucose output, we had found that in both cases that the glucose ingestion was successful at reducing hepatic glucose output comparably. Again, suggesting that the liver is not playing a role in the difference in postprandial glucose. So then we went to skeletal muscle, and part of my exercise background got excited because it's got to be the muscle then, if it's not these other organs. And in fact, that's what we found. When we looked at peripheral insulin resistance, we had found significant reductions following the whole grain trial, but there was no change after refined grains, suggesting overall that whole grains are acting on the skeletal muscle to stimulate glucose uptake and lower postprandial glucose levels. And how might that be working? Well, in looking at indirect calorimetry, we had measured fat oxidation. We found that in the resting state, fat oxidation was significantly elevated compared to refined grains. And this was corroborated by changes in metabolic flexibility, suggesting that whole grains increase insulin-stimulated carbohydrate oxidation compared to refined grains. So there's something about the whole grains that are actually altering fuel selection in these obese pre-diabetic patients. But what about the pancreas? Because generally speaking, when you improve insulin sensitivity, you should reduce the amount of insulin need to be secreted from the pancreas. Quite surprisingly, though, when we looked at C-peptide concentrations and focused on glucose-stimulated insulin secretion, we found relative to baseline that whole grains had raised insulin secretion relative to refined grains. And this was supported further when scaling this to the ambient changes in insulin resistance, suggesting overall that whole grains actually improve beta cell function in combinations with improvements in peripheral insulin resistance. So I recognize there was a lot of information there thrown at you. So in summary, independent of any weight loss, it seems that whole grains are successful at reducing blood pressure. And also in favoring glycemic control by either affecting skeletal muscle and or the pancreas to a large extent. And at the same time, there seems to be some direct effects of the whole grains in actually favoring alterations in fuel selection, which may help understand better the changes in skeletal muscle and pancreas. So some of the future questions that I'd like to address as a faculty member would be, really, how do low-fat diets contribute to changes in insulin sensitivity? Particularly when it comes to the exercise and metformin question. As we found that metformin was blunting some of the exercise effect. Could this be through alterations in diet to try and rescue some of the inflammatory pathways that we saw were elevated? At the same time, given the whole grain findings, I think it'd be quite interesting to understand what happens when you combine whole grain intake with blood glucose regulation in type 2 diabetics. There's no current work on that topic, and could it be related to the changes in insulin resistance? So with that being said, I'd like to shift gears a little now to really the role of physical activity and exercise dose. And that this is an area that has received attention, but largely from a cardiovascular standpoint. I don't know if we have great understandings of how to prescribe it relative to diabetes. In particular, thinking about this through the paradigm of insulin secretion and beta cell function, when you look at the levels of blood glucose ranging from normal to pre-diabetes or impaired glucose tolerance to type 2 diabetes, we can see that looking at an individual relative to mean status, that an obese pre-diabetic person will have anywhere from a 50 to an 80% loss of beta cell function by the time they're about to cross the finish line of diabetes. And this is quite troubling, thinking then, how do we go about treating the disease? Perhaps we need to also consider then treatments that are going to potentiate the ability to secrete insulin relative to the changes in insulin resistance, such that we can shift this obese pre-diabetic patient back to normality. So the question then is, what exercise do we actually use? And there was some nice work published out of Greg Goodpasture's lab a few years ago showing that when looking at a 12 to 16 week intervention, primarily consisting of aerobic exercise, that the change in insulin sensitivity here was correlated with the increased volume of exercise performed per week, such that expending 2,000 calories yielded a greater improvement in insulin sensitivity than an individual expending 500 calories or more. We had looked at this also from a beta cell function perspective to try and gain some insights, and what we had found was something quite similar. As individuals had exercised with greater energy expenditure, there was a reciprocal or linear increase in beta cell function. Suggesting collectively, when thinking about insulin action in the body, that higher volumes are better. So what we had done was looked at some study design to think about this from a personal exercise perspective, in that we wanted to conduct vast training and criteria measures to understand the personalization of exercise. So all individuals underwent physical screenings to ensure safety and appropriate health measures were included, such as to not have any heart disease that would be conflicting with exercise. Individuals also went under a 3-day weight stabilization period in our clinical research unit, in which then measures of body composition, fitness, fuel selection, glucose, and insulin metabolism were assessed. In terms of our intervention, thinking about the fact that low-fat diets and high volumes of exercise may be potentially maximal in ameliorating insulin resistance, improving insulin secretion, and lowering blood glucose, we use this prescription to assess all these factors 12 weeks following the intervention. So in collaboration with Tom Solomon at the University of Copenhagen, we looked at 105 patients who had ranges from normal glucose tolerance to type 2 diabetes. And we looked at how they responded to this intervention following 12 weeks. In this case, what we had noticed, quite surprisingly, but in line with the Heritage findings, is that around 30 to 33% of individuals actually had elevations in blood sugars following this intervention. And I say that's in line with the Heritage study because they had also noted rises in fasting insulin and blood lipids in about 20 to 30% of their cohort. And these data could be particularly important because baseline hemoglobin concentrations as a measure of glycemic control were inversely related to the change in cardiorespiratory fitness, such that this might suggest pre-existing hyperglycemia is an important biomarker for understanding exercise responsiveness. And I was particularly interested in terms of the prediabetes pathology, as our current definitions from the ADA, American Diabetes Association, not the American Dietetic Association, would suggest that here it could be defined as either impaired fasting glucose and or impaired glucose tolerance, such that you actually could have 3 clinical populations of prediabetes. And if you were to conduct an oral glucose tolerance test, their profiles would be vastly different. And that's suggestive of different underlying pathologies in insulin resistance and insulin secretion. So with this in mind, I wanted to look at, in retrospective analysis with my current director, John Kerwin, what is the role of these individuals ranging the pre-diabetic spectrum in response to low-fat, high-volume exercise program. And what we found was, quite interestingly, in the presence of impaired fasting glucose, those individuals with IGT had blunted reductions in their 2-hour blood glucose levels. But clinically is suggesting that they're not able to reverse their pre-diabetic state as readily as their aging weak counterparts. To gain more mechanistic insight into this, we had used stable isotopes to look at the rate of glucose disposal into the skeletal muscle, and we found blunted reductions, or blunted improvements rather, in this insulin sensitivity marker. And this was corroborated by the change in substrate oxidation. So this overall correlation between the magnitude of change in metabolic flexibility and insulin sensitivity has actually been corroborated by previous work out of Larry Mandarino's group, showing that in obese individuals undergoing a single bout of intense exercise, that there's no rise in PGC1 alpha, which, as many of you know, probably better than I do, it's an important mitochondrial biogenesis marker. So in this sense, there may be something about a metabolically unhealthy state that actually impacts fuel selection and the abilities to improve health. And I think clinically this is quite relevant as people get frustrated with no improvements. And actually this leads to doubt whether they should even continue with their current exercise and diet program. So with that being said, another area of interest I have is understanding how do we prescribe exercise to this disease state. And would low intensity exercise, but maintaining a high volume, be beneficial? Perhaps this would alter the metabolic fluxes in which these individuals are going through and essentially allow metabolic adaptation to occur. And also, what's quite interesting, we've had some great conversations surrounding children on this, is children, although not little adults and do not have the same exact physiology, in this context do, at least from current interventions or current baseline trials, I should really say. And we don't know whether children would have similar responses or differential responses based on the biomarker of blood glucose. Also, I'd be really interested in trying to understand how do you tailor diet to this? Because if the pathology is different, does that mean they need a different diet in conjunction with their exercise program? And we had talked a lot about the roles of low-carb diets and low-fat diets, but really the understanding of what diet goes with what disease state hasn't been well explored, to my knowledge, as of yet. And lastly, what are the mechanisms that really explain this blunting phenomenon seen in adults with the presence of both impaired glucose tolerance states? Is it related to higher lipid species through de novo lipogenesis of hyperglycemia? Is it oxidative stress? Is it inflammation? There are a whole host of factors that could be playing a role, but we really don't understand the molecular mechanism in this state. And that could be beneficial in understanding not only combined future treatment, but also understanding pharmacological intervention as well. So with that being said, I wanted to spend the last few minutes of my talk with bariatric surgery. Because as I said, with exercise, at least anecdotally, I've witnessed at the Cleveland Clinic, many patients tell me how frustrated they become with no responses. And whether that's their blood sugars aren't improving, or they're not losing the weight, they get incredibly frustrated and want surgery. In fact, we had a patient undergo randomizations of lifestyle modification or bariatric surgery. And this woman went to lifestyle modification. After 9 months, she wasn't getting anywhere. It didn't matter how hard we counseled, it didn't matter what we were telling her to do. Her biochemical markers and body weight were not budging. And essentially, at that point, in speaking with her surgeon and counsels, she elected to go to surgery after the intervention. And what we had found from 9 months to 12 months, her metabolic health deteriorated rapidly. In looking at insulin sensitivity via the clamp, she essentially got worse by 100% in a 3-month matter of time. And just that idea of frustration came about. So with this being said, bariatric surgery in some ways is a last resort for some people. And maybe we should consider what role exercise and diet has in patients electing to go that route, to understand how we can prevent them from needing any medications following surgery. And of course, many of you are aware that people with diabetes are majorly in the obese state. And as we were mentioning, really, there's much frustration in these patients, and in some levels, a psychological feeling of defeat in terms of their poor responses to lifestyle interventions. Now, in terms of bariatric surgery, it has proven effect in the durability of weight loss and glycemic control. And in general, there are 3 mechanisms that are proposed to explain this phenomenon. If we go from a state of overnutrition, so sedentary lifestyle, either high caloric intake, high fat, high carbohydrate, either way, as we reduce that stimulation, so if you start to calorically restrict people, you'll notice that there are actually improvements in diabetes risk factors. If you restrict food intake, either through gastric banding or sleeve gastrectomy, which is removing approximately 80% of the stomach fundus, you'll see that this effect is exponentially better, or linearly, depending on how you do it, than diet alone. And when you ultimately look at gastric bypass, which is actually removing parts of the stomach and replumbing, as our bariatric surgeon Phil Shower likes to say, you'll note differential effects on really the level of improvement in diabetes risk factors. And with each of these conditions, caloric restriction is involved. But as you progress from the overstimulated state to gastric bypass, you see changes in malabsorption occurring, as well as gut hormones. So collectively, this myriad of mechanisms may play a role in the amelioration of insulin resistance, beta cell dysfunction, and improved glycemic control. But from a clinical standpoint,